Digoxin inhibits the sodium-potassium adenosine triphosphatase pump in cardiac myocytes, which increases intracellular sodium. This change enhances calcium entry through the sodium-calcium exchanger, raising intracellular calcium availability and strengthening myocardial contraction. The result is a positive inotropic effect, improving stroke volume and overall cardiac output in infants with reduced ventricular function. Simultaneously, digoxin exerts a negative chronotropic effect by increasing vagal tone at the atrioventricular node. This slows conduction through the AV node and can help control ventricular rate in atrial tachyarrhythmias, making it valuable in infants with supraventricular tachycardia or heart failure complicated by rapid atrial rhythms. Digoxin has a narrow therapeutic window, meaning that small changes in serum levels, renal function, or electrolyte status can result in toxicity. Careful dosing and ongoing monitoring of renal function, electrolytes, and heart rate are essential to maximize benefit while minimizing risk. Digoxin is particularly valuable in infants with congestive heart failure when atrial arrhythmias coexist. By slowing atrioventricular conduction, it helps control ventricular rate, preventing tachycardia-induced worsening of cardiac output while simultaneously enhancing contractility. In supraventricular tachycardia, digoxin prolongs AV nodal refractory periods, stabilizing ventricular response and allowing improved hemodynamic performance. Similarly, in atrial fibrillation, its effect on the AV node helps prevent excessively rapid ventricular rates, reducing the risk of low cardiac output and pulmonary congestion. For infants with cardiomyopathy and systolic dysfunction, digoxin's positive inotropic effect increases stroke volume, supporting systemic perfusion without excessive increases in myocardial oxygen consumption. Although not a first-line therapy for all neonatal heart failure, digoxin is highly useful in select situations where rate control or contractility support is required. Its use must be guided by careful attention to dosing, renal function, and serum electrolytes to remain within the narrow therapeutic window and avoid toxicity. Digoxin dosing in neonates is guided by the principle of digitalization, which rapidly establishes therapeutic serum levels while minimizing toxicity. The total digitalizing dose, generally 8 to 10 micrograms per kilogram, is administered in divided portions. The first half of the dose is given initially, followed by 1/4 at 6 to 8 hour intervals twice. This stepwise approach allows the drug to reach effective myocardial concentrations gradually, reducing the risk of bradyarrhythmias or gastrointestinal intolerance. Maintenance therapy typically ranges from 2 to 4 micrograms per kilogram per day, divided every 12 hours by mouth. Neonates require higher weight-based doses compared with older infants because of increased volume of distribution and immature renal clearance, which accelerates drug elimination relative to older children. Monitoring during digitalization and maintenance is essential. Observe heart rate, rhythm, and feeding tolerance, and track serum electrolytes, particularly potassium, since hypokalemia increases susceptibility to digoxin toxicity. By applying age-appropriate dosing and careful fractionation of the total dose, clinicians achieve reliable inotropic and rate-controlling effects while minimizing adverse events. Effective digoxin therapy requires precise monitoring because of its narrow therapeutic window. The target serum concentration is generally 1 to 2 nanograms per milliliter, which provides adequate inotropic support without precipitating toxicity. Levels above 2 nanograms per milliliter significantly increase the risk of arrhythmias, feeding intolerance, and gastrointestinal symptoms. Blood sampling should occur 6 to 8 hours after a dose, rather than at the peak, to reflect true circulating drug levels. This timing avoids overestimation and ensures dosing adjustments are based on steady pharmacokinetics. Steady-state concentrations are typically achieved after 5 to 7 days of consistent dosing, which is essential to interpret levels accurately. Regular monitoring of serum digoxin, combined with assessment of heart rate, rhythm, and electrolytes, allows clinicians to maintain therapeutic effect while minimizing toxicity. The process ensures safe and effective inotropic and rate-controlling therapy, particularly in neonates whose renal function and drug clearance are highly variable. Digoxin toxicity arises from excessive inhibition of the sodium-potassium ATPase pump, which alters intracellular calcium and sodium balance in cardiac myocytes. Cardiac manifestations include a broad spectrum of arrhythmias, ranging from atrioventricular block to ventricular ectopy, and can occur even when the heart rate appears only mildly affected. Gastrointestinal effects, such as nausea, vomiting, and anorexia, are early indicators of toxicity and often precede overt cardiac events. Central nervous system effects, including irritability, lethargy, or visual disturbances, may also signal digoxin accumulation. In neonates, early signs are frequently non-cardiac, making vigilance critical. Several factors increase susceptibility to toxicity. Hypokalemia, hypomagnesemia, and hypercalcemia potentiate digoxin's effect on myocardial excitability. Renal dysfunction reduces clearance and allows accumulation. Concomitant medications, particularly those affecting renal function or electrolyte balance, further elevate risk. Monitoring serum electrolytes, renal function, and observing for subtle clinical signs enables timely detection of toxicity. Adjusting doses in response to these parameters ensures that digoxin provides inotropic support and rate control safely without crossing the narrow therapeutic threshold. Digoxin is contraindicated in conditions where its effects on conduction or contractility could worsen hemodynamics. In hypertrophic cardiomyopathy with left ventricular outflow tract obstruction, positive inotropy can increase the gradient across the obstructed area, reducing cardiac output and risking syncope or collapse. Ventricular tachycardia is another contraindication, as digoxin's effect on conduction may exacerbate arrhythmias or precipitate degeneration into more malignant rhythms. Second or third degree atrioventricular block is a concern because digoxin slows AV nodal conduction. In the absence of a functioning escape rhythm, this can lead to profound bradycardia or cardiac arrest. Known hypersensitivity to digoxin or its components also precludes use, as administration may trigger severe allergic reactions. In all these situations, extreme caution is required. If digoxin is considered despite relative risk, dosing must be minimal and continuous monitoring of rhythm, heart rate, and electrolytes is essential to detect early signs of toxicity or conduction compromise. Certain rare but important factors can alter digoxin's effectiveness or safety profile. Caffeine can decrease digoxin's efficacy, likely by enhancing renal clearance or increasing diuresis, which reduces circulating drug levels. Electrolyte disturbances, particularly low potassium or magnesium and high calcium, magnify digoxin's effect on cardiac myocytes, increasing the risk of arrhythmias. Early toxicity in neonates often presents with non-cardiac signs, including vomiting, poor feeding, or lethargy, rather than immediate rhythm changes. Renal impairment or concurrent medications that affect clearance necessitate dose adjustment to maintain therapeutic levels without exceeding the narrow safety margin. Awareness of these uncommon interactions ensures digoxin is used safely and effectively in the neonatal population. Propranolol is a non-selective beta-adrenergic receptor antagonist that blocks both beta-1 and beta-2 receptors. Beta-1 blockade reduces heart rate, myocardial contractility, and oxygen consumption, which can improve hemodynamics in infants with certain arrhythmias or hyperdynamic states. Beta-2 blockade can lead to bronchoconstriction, which is important when considering use in patients with reactive airways. Clinically, propranolol is used for systemic hypertension, to control supraventricular and atrial arrhythmias, and for tetralogy of Fallot spells, where reducing heart rate and contractility decreases right-to-left shunting and improves oxygenation. Dosing typically ranges from 0.5 to 8 milligrams per kilogram per day, divided every 6 to 12 hours. The wide range allows titration according to heart rate, blood pressure, and response in infants of varying gestational and postnatal age. Side effects arise from both cardiac and non-cardiac mechanisms. Bradycardia and hypotension are direct results of beta-1 blockade, while bronchospasm stems from beta-2 inhibition. Hypoglycemia can occur because beta blockade impairs glycogenolysis, making infants particularly vulnerable during fasting or stress. Contraindications include asthma and severe heart failure, where beta-2 or beta-1 blockade would exacerbate bronchospasm or reduce cardiac output further. close monitoring of heart rate, blood pressure, and respiratory status is essential to safely achieve therapeutic benefit. Atenolol is a cardioselective beta-1 adrenergic receptor blocker. By primarily targeting beta-1 receptors in the heart, it decreases heart rate and myocardial contractility, which in turn reduces cardiac workload and lowers blood pressure. Its limited activity on beta-2 receptors makes it less likely to provoke bronchospasm, an important consideration in patients with underlying respiratory disease. Clinically, atenolol is used for managing hypertension and for treating certain tachyarrhythmias. The oral dosing ranges from 0.5 to 2 milligrams per kilogram per day, administered every 12 to 24 hours, with careful titration based on heart rate, blood pressure, and clinical response. The advantages of atenolol over non-selective beta blockers, such as propranolol, include a lower risk of bronchospasm and minimal interference with peripheral vascular resistance, making it the preferred agent in patients with pulmonary concerns or reactive airway disease. Monitoring should focus on blood pressure, heart rate, and signs of excessive beta blockade, such as fatigue or bradycardia. Amiodarone is a Class 3 antiarrhythmic that prolongs the myocardial action potential by delaying repolarization. This effect stabilizes cardiac conduction and refractory periods, making it effective for controlling both supraventricular and life-threatening ventricular arrhythmias. Its mechanism also suppresses reentrant circuits, which are a common source of tachyarrhythmias in neonates. Clinically, amiodarone is reserved for severe or refractory arrhythmias, including sustained ventricular tachycardia and supraventricular tachycardia that does not respond to first-line therapies. Its use is considered when the risk of ongoing arrhythmia outweighs potential adverse effects. Dosing typically begins with an intravenous loading dose of 5 to 10 milligrams per kilogram, followed by a continuous infusion of 5 to 15 micrograms per kilogram per minute. This regimen achieves therapeutic myocardial concentrations while allowing careful titration based on rhythm response and hemodynamic stability. Side effects reflect the drug's multi-system activity. Pulmonary toxicity can manifest as interstitial pneumonitis or fibrosis, thyroid dysfunction occurs due to iodine content, and hepatotoxicity results from direct cellular effects. Because of these potential complications, amiodarone is used only in serious arrhythmias under close monitoring of respiratory function, thyroid and liver tests, and electrocardiographic changes. Flecainide is a Class 1C antiarrhythmic that blocks fast sodium channels in cardiac myocytes, slowing depolarization and reducing conduction velocity. This stabilizes atrial and ventricular tissue, particularly in reentrant circuits, which are common causes of supraventricular tachycardia in neonates. Clinically, Flecainide is used for prophylaxis of SVT and in infants with Wolff-Parkinson-White syndrome, where accessory pathways predispose to rapid conduction and hemodynamic compromise. Its efficacy relies on suppressing aberrant conduction without significantly altering sinus node function. The typical oral dose is 1 to 3 milligrams per kilogram every 8 to 12 hours. Neonates are highly sensitive to small changes in dose due to variable absorption and renal clearance, so careful titration is required. Monitoring focuses on electrocardiographic intervals to detect QRS widening, PR prolongation, or other proarrhythmic effects. Flecainide can paradoxically induce arrhythmias if serum levels are excessive or in the presence of structural heart disease, making ECG surveillance essential. Flecainide is most often employed as outpatient maintenance therapy in infants with stable but recurrent arrhythmias, allowing long-term rhythm control while minimizing hospital exposure. Its use should be individualized based on cardiac anatomy, conduction properties, and risk of proarrhythmia. Nitroprusside is a potent vasodilator that acts directly on vascular smooth muscle, causing relaxation and rapid reduction in systemic vascular resistance. This decreases afterload, allowing the ventricle to eject blood more effectively and improving cardiac output in infants with left ventricular dysfunction or severe pressure overload. Its primary applications include management of hypertensive crises and acute afterload reduction in heart failure. By rapidly lowering systemic resistance, nitroprusside alleviates excessive ventricular wall stress and reduces myocardial oxygen demand. Dosing is administered as a continuous intravenous infusion, typically ranging from 0.3 to 10 micrograms per kilogram per minute, titrated to blood pressure and perfusion targets. Because of its potent effect, hypotension can develop quickly if the infusion rate is excessive, necessitating careful hemodynamic monitoring. Prolonged use carries the risk of cyanide accumulation, which can lead to metabolic acidosis and cellular toxicity. For this reason, Nitroprusside is reserved for short-term interventions, bridging patients until longer-acting therapies or corrective measures can be implemented. Nicardipine is a calcium channel blocker that selectively targets vascular smooth muscle, producing vasodilation without significant negative inotropic effects. By inhibiting calcium entry into smooth muscle cells, it reduces systemic vascular resistance and afterload, improving forward cardiac output while minimizing depression of myocardial contractility. Its primary applications in neonates include management of systemic hypertension and controlled afterload reduction in patients with ventricular dysfunction. Nicardipine allows gradual blood pressure lowering, avoiding abrupt drops that could compromise organ perfusion. Dosing is delivered as a continuous intravenous infusion, typically between 0.5 and 4 micrograms per kilogram per minute, titrated according to hemodynamic response. The minimal effect on heart rate and contractility makes it preferable over non-selective vasodilators in infants who are vulnerable to hypotension or low cardiac output. Because of its predictable pharmacodynamics, nicardipine is favored when controlled. Precise reduction of blood pressure is required, such as in post-surgical hypertension or afterload-sensitive heart failure. Continuous monitoring of blood pressure, perfusion, and electrolytes ensures safety and effectiveness during therapy. Maintaining optimal electrolyte balance is essential for cardiac stability and safe pharmacologic therapy in neonates. Potassium should be maintained between 4 and 5 milliequivalents per liter. This is especially important when digoxin is used, as low potassium levels enhance digoxin's effect on the sodium-potassium AT-PACE pump, increasing the risk of arrhythmias and toxicity. Magnesium should be kept above 1.8 milligrams per deciliter because it stabilizes myocardial cells and supports normal conduction. Deficiency predisposes infants to ventricular arrhythmias, particularly when diuretics are used or rapid electrolyte shifts occur. Ionized calcium should be maintained between 1.1 and 1.3 millimoles per liter. Calcium is essential for myocardial excitation-contraction coupling, and deviations can reduce contractility or alter heart rate. Sodium levels must be corrected gradually to avoid rapid changes, which can shift osmolality and cause neurologic complications, including seizures or cerebral edema. Overall, maintaining electrolyte balance is critical to ensure the safety and efficacy of cardiac medications. Monitoring potassium, magnesium, calcium, and sodium allows anticipatory adjustments, reducing the risk of drug-related toxicity and supporting stable cardiac function. Neonatal congestive heart failure develops from a combination of volume overload, pressure overload, or impaired ventricular contractility. Elevated preload increases pulmonary venous pressures, producing pulmonary edema, hepatomegaly, and systemic fluid retention. Increased afterload forces the ventricle to work against higher resistance, promoting hypertrophy and reducing forward cardiac output. Diuretics target preload, removing excess fluid and alleviating congestion. ACE inhibitors lower afterload, improving forward output while limiting maladaptive remodeling. Digoxin enhances intracellular calcium availability, increasing contractility and supporting systolic function. Beta blockers modulate heart rate and sympathetic activity, reducing oxygen demand and arrhythmia risk. Vasodilators provide short-term afterload reduction and systemic perfusion support. Integrating pathophysiology with pharmacology clarifies why each drug class is selected, how they complement one another, and what physiologic effect is being addressed in specific neonatal CHF scenarios. Monitoring renal function is fundamental in infants receiving cardiac medications, as kidney performance directly affects drug clearance and doing. Creatinine clearance reflects glomerular filtration and guides adjustments for medications that are renally eliminated, such as digoxin and certain antiarrhythmics. Urine output should be maintained above 1 milliliter per kilogram per hour. Sustained oliguria may indicate impaired renal perfusion or acute kidney injury, which can elevate drug levels and increase toxicity risk. Fluid balance should be closely tracked using daily weights and accurate intake and output measurements. This assessment informs adjustments to diuretic therapy and overall volume management, preventing under or over diuresis. Drug levels, particularly for narrow therapeutic window agents like Digoxin and select antiarrhythmics, should be monitored as indicated. Serum levels allow identification of accumulation before clinical toxicity develops. When renal impairment is detected, dosing adjustments are essential. Reducing doses or extending dosing intervals helps maintain therapeutic effect while preventing toxicity. Integrating creatinine clearance, urine output, fluid balance, and drug levels ensures safe and effective pharmacologic management in neonates with evolving renal function. Continuous telemetry provides real-time assessment of heart rhythm and rate, enabling early detection of arrhythmias or conduction abnormalities, which can be life-threatening in neonates with cardiac compromise. Frequent blood pressure monitoring, including four-extremity measurements, identifies hemodynamic instability, detects gradients from obstructive lesions, and guides titration of vasoactive or antihypertensive therapies. Perfusion assessment, through capillary refill and evaluation of pulse quality, offers immediate insight into systemic blood flow and cardiac output, supplementing numeric blood pressure readings. Echocardiography allows detailed evaluation of ventricular function, chamber size, and response to medical interventions, supporting precise adjustments to pharmacologic therapy. Daily clinical assessment of heart failure symptoms, including tachypnea, feeding difficulty, hepatomegaly, and weight changes, integrates physiologic monitoring with functional status, ensuring that treatment efficacy and early deterioration are identified promptly. Together, these monitoring strategies provide a comprehensive understanding of cardiovascular status, guide therapy, and allow rapid response to changes in neonatal cardiac function. Drug interactions can significantly amplify the effects or toxicities of cardiovascular medications in neonates, making careful review essential. Concurrent use of ACE inhibitors with potassium-sparing diuretics increases the risk of hyperkalemia, because both reduce renal potassium excretion, which can precipitate life-threatening arrhythmias. When digoxin is combined with loop or thiazide diuretics, hypokalemia may develop. Low potassium potentiates digoxin's effect on the sodium-potassium AT-PACE pump, increasing the likelihood of arrhythmias and gastrointestinal toxicity. Beta blockers and calcium channel blockers have additive effects on the sinoatrial and atrioventricular nodes. This combination can cause profound bradycardia or heart block if not monitored carefully. Using multiple antiarrhythmic agents simultaneously raises the risk of pro-arrhythmic effects due to overlapping actions on conduction and refractoriness, which may paradoxically precipitate dangerous tachyarrhythmias. Before initiating any new medication, clinicians should systematically review potential interactions with the existing regimen. Understanding the pharmacodynamic and pharmacokinetic interplay allows safe combination therapy, minimizes adverse events, and ensures that therapeutic goals are achieved without compromising neonatal cardiac stability. Neonates and young infants have immature drug metabolism, leading to prolonged half-lives for many cardiovascular medications. Hepatic enzyme systems, particularly cytochrome P450 pathways, are underdeveloped, slowing clearance and increasing the risk of accumulation. Protein binding is also altered in this population. Lower levels of albumin and alpha-1 acid glycoprotein result in higher free drug concentrations, which magnify pharmacologic effects and the potential for toxicity. Pharmacokinetics differ significantly from older children and adults, including slower renal clearance, reduced volume of distribution for some agents, and altered absorption. These differences necessitate careful dosing adjustments and frequent monitoring. Infants are more sensitive to cardiovascular effects, such as bradycardia, hypotension, or arrhythmias. Even standard doses in older children may produce exaggerated responses. The start low, go slow principle applies universally in this population. Initiating therapy at the lowest effective dose and titrating gradually allows clinicians to achieve therapeutic benefit while minimizing adverse effects, accounting for both physiologic immaturity and variable drug handling. Renal impairment significantly affects the pharmacokinetics of many cardiovascular medications in neonates, requiring thoughtful adjustments to maintain efficacy while avoiding toxicity. Drugs that are renally eliminated, such as Digoxin and certain antiarrhythmics, accumulate when glomerular filtration is reduced, necessitating dose reductions or extended intervals between administrations. Enhanced monitoring is critical in this population. Serum drug levels, renal function tests, and close observation for early toxicity signs, including arrhythmias, hypotension, or feeding intolerance, help guide safe therapy. Fluid restriction may be necessary in cases of oliguria or volume overload, but it must be balanced against maintaining adequate perfusion and supporting growth. Particular attention is warranted for ACE inhibitors and digoxin, both of which rely on renal clearance. Inadequate adjustment can rapidly lead to hyperkalemia, hypotension, or digoxin toxicity. By integrating renal function assessment into drug selection, dosing, and monitoring, clinicians can safely use potent cardiovascular medications while minimizing adverse effects in neonates with impaired kidney function. Hepatic impairment in neonates alters the metabolism of drugs cleared by the liver, including many cardiovascular medications. Reduced activity of cytochrome 450 enzymes slows drug biotransformation, increasing systemic exposure and prolonging half-life. Impaired protein synthesis reduces the availability of albumin and other binding proteins, increasing the free fraction of highly protein-bound drugs and potentiating pharmacologic effects and toxicity. Altered synthesis of coagulation factors adds risk when anticoagulants or agents affecting platelet function are administered, as bleeding complications may occur more readily. Dose reductions or extended dosing intervals may be required for hepatically cleared medications to maintain therapeutic effect while avoiding adverse outcomes. Continuous monitoring of liver function, drug levels, and clinical response ensures safe and effective therapy in infants with hepatic dysfunction. Initiating therapy with low doses and titrating slowly is essential because neonates have immature metabolic and renal pathways, making them highly sensitive to even standard drug doses. Rapid titration can precipitate hypotension, bradycardia, or arrhythmias. Electrolytes, particularly potassium, must be monitored closely. Hypokalemia increases the risk of digoxin toxicity, while derangements in magnesium, calcium, or sodium can exacerbate arrhythmias or impair contractility. Drug interactions are common and can amplify or blunt the effect of medications. For example, combining ACE inhibitors with potassium-sparing diuretics can provoke hyperkalemia, while diuretics combined with digoxin increase the risk of toxicity through electrolyte shifts. Digoxin toxicity in neonates often presents with non-cardiac signs first, including nausea, vomiting, or feeding intolerance. Recognizing these early clues is critical to prevent life-threatening arrhythmias. ACE inhibitors may produce first-dose hypotension due to abrupt reduction in systemic vascular resistance. Careful initial dosing mitigates this risk. Furosemide is effective for volume overload, but can produce significant electrolyte disturbances and dehydration, emphasizing the need for frequent laboratory monitoring and weight assessment. Together, these principles guide safe and effective use of CHF medications, balancing therapeutic benefit with minimization of adverse effects. Regular monitoring of drug levels is crucial for medications with narrow therapeutic windows, such as digoxin or certain antiarrhythmics, to prevent accumulation and toxicity. Establishing electrolyte replacement protocols ensures that imbalances from diuretics or other agents are corrected promptly, reducing the risk of arrhythmias and hemodynamic compromise. Errors in drug concentration or calculation can be fatal in neonates due to their small size and sensitivity, making verification of doses imperative before administration. Patient-specific factors, including gestational and postnatal age, renal and hepatic function, and concomitant medications, affect drug pharmacokinetics and pharmacodynamics and must inform dosing adjustments. When multiple cardiac medications are used simultaneously, clear communication among the care team is essential to coordinate monitoring, titration, and response evaluation. Structured communication minimizes errors, ensures safe transitions between agents, and allows timely identification of adverse effects. Implementing these safety strategies maintains the balance between therapeutic benefit and risk, optimizing outcomes while minimizing complications from potent cardiovascular medications. Therapy for neonatal heart failure must be individualized according to the underlying etiology, whether due to structural lesions, myocardial dysfunction, or high output states. Starting medications at the lowest effective dose and titrating gradually reduces the risk of hypotension, bradycardia, or toxicity. Maintaining electrolyte balance is essential for both safety and efficacy. Potassium, magnesium, calcium, and sodium influence myocardial excitability, conduction, and response to agents such as digoxin, diuretics, and ACE inhibitors. Drug interactions are frequent and can significantly amplify or blunt therapeutic effects. Checking for interactions before adding new medications helps prevent hyperkalemia, arrhythmias, or unexpected hemodynamic compromise. Regular monitoring, including drug levels, blood pressure, heart rate, renal and hepatic function, and clinical response, ensures therapy achieves its intended effect while minimizing adverse events. Effective neonatal heart failure management relies on integrating knowledge of multiple drug classes, their pharmacologic interactions, and the physiologic status of the infant to optimize outcomes while safely minimizing complications.